It's a prospective comparative study of the preoperative chemoradiotherapy followed by surgery versus upfront surgery followed by adjuvant chemoradiotherapy in locally advanced borderline resectable oral cavity cancers. It was conducted in, it was, sir, the authors are Aishna, Surbhi Gupta, Akhil Pratap Singh, and Varun Agarwal. They are from the Department of Radiation Oncology, ENT, and Surgical Oncology at the Sarojini Naidu Medical College, Agra. And it was the duration of study is from October 22 to the March 24. It was published in Journal of Cancer Research and Therapeutics and on 5th of July 2025. The background and need for this study is that we usually get a large number of locally advanced modern resectable oral cavity cancers in our OPDs, mainly T3, T4 disease, or even sometimes T4B disease with nodal N2, N2, N2A, N2B disease as well. And in such cases, after the surgery, there is a high risk of post-operative local site recurrence as well. So the focus of this study is to evaluate the feasibility and efficacy of NSCRT followed by surgery. The secondary endpoints are to evaluate the clinical and pathological response rate at primary and nodal sites, to evaluate the post-operative morbidity in patients receiving NSCRT, and to compare the margin status in the patients receiving NSCRT followed by surgery versus upfront surgery. It is a prospective comparative case-controlled study. The inclusion criteria are histologically proven squamous cell carcinomas of oral cavity having T3, T4 disease and nodal status of N0, N1, N2B, N2C. It was a single-blinded study and patients were randomized on the odd and even basis. Odd numbers patients were taken for upfront surgery. 36 patients were enrolled and out of them 31 completed the treatment, and even numbers were taken for NSCRT followed by surgery, in which the 40 patients enrolled but only 26 patients completed the treatment. This is the PICO framework of the study. The population, as I said, is histologically proven locally advanced modern resectable oral cavity cancers. The intervention studied was NSCRT followed by surgery, plus or minus adjuvant chemoradiotherapy, and it was compared to the upfront surgery followed by adjuvant chemoradiotherapy. The outcome was that the use of NSCRT in borderline resectable cancers is not just effective but also feasible with comparable side effects. The time frame of the study was 18 months from October 22 to March 24. The study design, the patients were randomized into the two arms. Arm A is a study arm and arm B is a control arm. In the study arm, the patients were given NSCRT of 46 gray and 23 fractions at the rate of 2 gray per fractions with 5 fractions per week. During this, the patients were assessed every weekly for the acute toxicities like mucositis, dermatitis, and hematological parameters. And after 6 to 8 weeks of completion of, after 4 weeks of completion of NSCRT, patients were assessed for clinical and radiological examination using RECIST criteria 1.1. And after 6 to 8 weeks, patients were underwent definitive surgery. And then further 6 to 8 weeks, patients were underwent adjuvant CTRT depending on the post-op SP report. While on this control arm, patients were taken up for the upfront surgery and then taken up for the adjuvant chemoradiotherapy. In the adjuvant chemoradiotherapy, 60 to 60 gray dose were used, and in the both the chemotherapy used was cisplatin or the carboplatin. This is the tumor characteristics in which as we can see, the most of common location of the tumors are at the buccal mucosa in both the groups, that is 57.7% and 54.84%, and 22 out of 26 patients in the arm A were having stage 4A disease, and 30 out of 31 patients in arm B having stage 4 disease, and maximum number of patients having moderately differentiated squamous cell carcinoma. For the demographics, the maximum number of patients are males, and mainly because attributed to substance abuse, either it been with smoking, tobacco chewing, or alcohol. This is the comparison of clinical and pathological T stage in arm A, that is NSCRT followed by surgery group. According to these, the 12 patients were having T4A disease on the clinical examination, and 4 patients were having T4B disease. And after the completion of the treatment, the pathological T stage for the T4A was 7 and T4B was 3. And also the PTX and PT1 numbers were also present there. Similarly, for the pathological end stage, for the pathological end assessment, patients having clinical N2B, N2C disease numbers are higher, that's 7 and 6, and pathological numbers are 2 and 3. Pathological N0 stage was also seen in the 18 patients. For the comparison of margin status of in the both arms, out of 26 patients in arm A, 22 patients had a negative margins, and the 31 on the arm B, after 21 patients had negative margins, but the p-value was 0.14 and it was insignificant. And at the 6 months follow-up, the total of 8 out of 18 patients in arm A and 10 out of 20 in the arm B had local regional failure, and remaining were the lost to follow. The side effects or toxicity profile were comparable to both arms. The grades of mucositis and hematologic toxicities were almost comparable in the both arms. 19 patients in arm and 22 patients in arm B developed xerostomia. Not a single patient developed osteoradionecrosis. And post-operative morbidity like graft rejection, bone dissection, hemorrhage were comparable in the both arms, but no details were mentioned about the numbers of the patients in the article. The difference in the side effect profiling was comparable, and so the cost of the managing the same, and ultimately the whole treatment was quite comparable. For this conclusion, given the article that NSAID has the potential to increase the rate of the pathological complete response, affecting both primary and neck nodal disease. The advantage of achieving negative residual margin is also present. The higher pathological response may serve as an indicator of improved disease-free survival and overall survival, but they have not specifically mentioned or uh, calculated for the same. The NSAID was well tolerated and with acceptable side effects and no post-operative morbidity. There are some limitations in this study based on the CONSORT 2010 checklist. First, in the title, they have mentioned they have not explicitly mentioned term randomized, but used the prospective comparative study, so it was partially reported. Same goes for the method trial design. No changes to the methods after the trial commencement were reported, and no changes to the trial outcomes were mentioned after trial commencement. For the sample size, no any sample size calculation or justification was provided. No any interim analysis or trial stopping guidelines were mentioned. For the randomization, they didn't use any true random sequence, but used an odd and even method. And any blocking or any restriction for the randomization were also not mentioned. For the after the randomization and the sequence for the allocation concealment of allocation sequence details were not provided. There were no specific mention of the who performed the specific roles, like who randomized the patient participants or who assigned the participants to specific interventions. They mentioned that it's a single blind study, but it does not specify who was blinded. The protocol diagram included in the study, but it does not fully gives details of number of patients screened, eligible, randomized, and lost to follow-up. And results were reported only partially. With primary, secondary outcomes were given, but the confidence interval was not given, so the precision is questionable. The absolute and relative effect sizes are not constantly reported for the binary outcome, and no any subgroup analysis or adjusted analysis were described. Similarly, no trial registration number was provided, or no any link or URL was given to access the trial protocol. Some other limitations which are not based on the CONSORT guidelines are the small sample size, high loss to follow-up, and having incomplete treatment, but there was no specific reason was mentioned that why the incomplete treatment was there. For in the in the NSAID group, 40 patients enrolled, but only 26 completed the treatment. There was short follow-up time for the local and nodal recurrence. For the clinical and pathological response, the RECIST was used for the clinical, but no specific pathological assessment criteria was defined. And incomplete reporting was there. For margin status, they compared arm A and arm B both, but for the clinical and pathological response in T and N stage, only it was shown in the study arm, but it was not compared to the control arm. The conclusion was also vague. They used as a, that it may be a indicator of the pathological response, may be an indicator of the improved disease-free survival or survival. There was overestimation of finding. In the article, they mentioned that the NSCRT unequivocally effective in treating the unequivocally effective in treating the tumors, and uh, uh, but then despite there is limitations like small sample size or insignificant p-value for margin stations as well. Incomplete contextualization was present. The article does not adequately discuss the specific challenges in treating the borderline resectable. In the article, the preoperative radiotherapy and neoadjuvant chemoradiotherapy terms were used interchangeably at different places without clearly saying the distinction in that. They have not mentioned any citations of large uh, trials of over the uh, borderline resectable cancers. There was overgeneralization of treatment options were given. The article mentioned that the surgery and radiotherapy are the two main treatment protocols for the borderline resectable oral cardiac cancers, but they did not specifically use the combined modalities, which was the whole focus of this study. There was incomplete toxicity reporting. The grading of the toxicities were given, but the criteria of the reporting were not mentioned. There was limited comparison with the prior studies like Yamakava et al. And Sushmita et al. In the discussion, but they in the discussion they mentioned the comparison of the T and N stage, which was comparable, but the study design of the both and the follow-up time was longer than the study. There was data inconsistency was also there in the text and table that there it was 69.55 for the end stage and 69.23 in the uh, text. And they mentioned that they have taken the informed consent for the and institutional ethics committee approval for the same, but there was no clear mentions regarding the whether the experimental nature of NSERT and potential risk for toxicity were explained. The clinical implication of this article is level 2B level of evidence, but due to multiple limitations and the quality of article is questionable, and whether to use the results in our day-to-day practice should be done with the caution. In the future, to change the treatment plan, think we should properly define the borderline resectable cancers, and rather than just solely depending upon the T3 TNM stage, but also should include the extent of the disease, like involvement of low ITF or high ITF diseases. And we need a large scale randomized clinical trials or meta-analysis to get the level 1 evidence and to implement in the practice.
Explain me, how does the study address N0 cases and elective neck dissection?
Specific mentions of elective neck dissections are in this study.
No, how did they actually define the borderline cases here?
Ma'am, they have used they in the inclusion criteria they taken the T3 and T4 diseases. In the inclusion criteria, ma'am, they have mentioned that T3, T4 disease and N0, N1, but they mentioned that borderline resectability was decided by the tumor board of the same institute, but no specific mentions were given about that. It was a limitation as well.
So they had few patients with N0 disease also?
Ma'am, they did have included in
They have
the
N0.
yes, ma'am.
But
Okay.
more importantly, they have T4B, which is inoperable
Sir,
disease.
And they have gone for upfront surgery in those patients also.
Yes.
Yes.
If you show the T stage bar chart,
Yes,
I think 4 and 3, you know.
sir, T4 and
You say it is 2B. I'll say it is a 3B evidence.
randomized comparable studies.
A 3B also poorly designed randomized control
Good.
studies or quasi-randomized control study or case control studies comes under 3B, because if you do even odd, it is actually not randomization.
Yes, sir. Yes, sir.
So you
Even
should
odd is
not
not
consider
good.
you should not consider it as a randomized control trial. You should
Okay.
consider it as a case control trial.
Okay.
So it will fall under 3B.